Right, so sixth presentation lecture for the MLA series. So this is faints, fits and funny turns. So this will take into account your seizures, your vasovagal syncopes and your faints, and other episodes of loss of consciousness or awareness. So when you consider loss of consciousness or blacking out, it's one of the most common presentations that present to emergency services, about 3.4 in 1,000. The easiest way to think about it is divided into three parts. So blood pressure related, dynamic blood pressure related, specifically cardiac, I know they sound quite similar, and neurological. And what will not determine the cause of the blackout is a scan or an EEG in the majority of cases. What you need is a good objective and subjective history. So that is taking into account what the patient tells you about what they experienced before they passed out, and then what they experienced immediately afterwards when they became aware, and any witness account that can tell you how they looked when they lost awareness. That is what will give you the diagnosis. When we have people coming to clinic and they have no awareness and there is no witness account, they can't tell you anything, you essentially have two people in a room who have no idea about an event that they weren't present for. So first is vasovagal syncope or a faint. Now, we all know what a faint looks like, but I think we forget to ask specific questions in history that will help us determine whether that's occurred. So essentially it's reduction of blood flow to the brain, and that causes usually a transient loss of awareness. It can be caused by structural heart problems, but in the majority of cases it's just dynamic blood flow. It's more common if people are dehydrated, unwell, if they're undernourished, so if people have been skipping meals. And the classic prodrome that we talk about is, people feel lightheaded, they might get roaring in their ears, they typically go pale, and they usually say something like, I'm going to go, or I feel like I'm going to pass out. They usually say quite distinctive things, and then they will go limp, and quite often almost sort of help themselves to the ground. They may go limp and then just go down like a sack of potatoes, but they may just sort of like go to their knees, go to their bottom, and then just sort of, and you should, if it's safe to do so, try and get their head down as much as you can, legs possibly up if you're able to, just to allow the blood to flow back to the brain. And there are quite famous YouTube videos of soldiers on parade who lost consciousness because they're standing completely still, because quite often now soldiers are instructed to kind of move their calves to allow the blood to keep circulating. So they start to faint and their fellow soldiers try and hold them up to stop them getting into trouble. And then they can get a secondary seizure because the blood is not getting to the brain. So if somebody does faint, you need to try and help them to the ground, or at least get their head down and support it. Now, you can get a few brief jerks in the context of a faint, so people can go down and then just have a couple of little jerks for a few seconds. There's quite a variation of how that can look. It can be bilateral, it can be unilateral, or people can just sort of stare around and say odd things, so just try and get their head down. And generally recovery is very quick. People will sort of get blood back to their face, they might go a bit red in the secondary way, feel a bit sick, may vomit, but generally recover. They know where they are, they know what's happened. They will say something like, oh man, did I pass out or did I faint? They'll know who you are, they'll know where they are, and that's how a faint looks. Now we contrast that to a seizure. So a seizure can be focal, so just affecting maybe one limb or one side, with consciousness not being affected, in which case it's not really relevant here. It can be complex or involving awareness, in which case you might have sort of one side of the body or sort of a chewing movement of the lips, and they may be technically awake but not responsive, or it can be generalized, which is what we usually think of as a seizure, a generalized tonic-clonic seizure. The aura is usually the origin of a seizure, and it is part of the seizure itself, and the description of the aura can let you determine where the seizure may have come from. We'll talk about that more in other lectures, but it's part of the evolving event. So things like deja vu, a feeling of ineffability, I know everything, or a strange smell, that's characteristic of a seizure originating in the temporal lobe. And they may or may not then develop a generalized convulsion as the wave spreads throughout the brain. Now the posture and the appearance of the blackout is quite different from that of a faint. So people will stiffen. If it's a generalized convulsion, people will stiffen And as they stiffen, they can also get contraction of the diaphragm and of the chest muscles. And they make often a sound which can be quite disturbing, like as the air is forced out. People describe it as very frightening. Their face may sort of contract, look quite rigid. The eyes are generally open. They may roll back. And initially, the colour may stay the same or go red due to the contraction. And then if the seizure is protracted, you might see them going purple or even blue. And that suggests that they're not getting sufficient oxygen to the brain. That's why we say if seizures don't terminate after 5 minutes, then you need to get medical attention as soon as possible. The tonic part is the stiffening, the clonic part is the rhythmic convulsion, which is generally bilateral. And then when the seizure terminates, people will then just go limp, and they may make a sort of snoring sound as the airways kind of collapse, and that's stertor, like that. So that's when you put somebody in the recovery position. And you can see how that would be quite different from the appearance of a faint. And people generally, if they've had a tonic-clonic seizure, they will have a delayed recovery. So they might be sort of unconscious or very drowsy for at least half an hour. Again, they may vomit, which is why it's important to put them on their side. But then they can become quite what we call cerebrally agitated or post-ictal after seizure and get quite annoyed, push people away, quite aggressive. And sometimes people who've had a seizure won't remember the seizure itself, you would expect. They won't remember a couple of hours after the event, and they may then find themselves in hospital because they don't recall being looked after by first responders, the ambulance coming and being taken to A&E. So they only kind of come to awareness and remember when they're in a hospital ward. And then we'll just touch on cardiac issues. It's not really in my sort of purview as a neurologist, but a dysrhythmia or an abnormal heart rhythm can cause a sudden collapse, possibly with reduced awareness, and they may feel some chest pain or an awareness that the heartbeat is abnormal. They may feel a lost beat or a skipped beat. It can be a brief loss of consciousness if it's just a transient or temporary abnormal rhythm. Aortic stenosis can cause faint-like episodes, but they would also we'd expect shortness of breath, symptoms of heart failure, maybe leg swelling or orthopnea, where people have to sit up, otherwise they get breathless. And they would have a significant systolic murmur. And this is why we have a stethoscope. So if somebody comes in with a collapse and it sounded transient and they've got any symptoms that might suggest heart failure or any collapse at all, really, just listen to their heart. You should listen to their heart. You should listen for carotid bruit as well. It's important. And I've just put here, and you can look at this in your own leisure, a comparison of syncope to seizure. You wouldn't expect syncope when sitting unless there's significant heart problems. And you'd expect that if you sat somebody down or lay them down, you might be able to abort the faint. We call that pre-syncopal. In a faint, you'd expect somebody to be pale. In a protracted seizure, you'd expect them to go red, purple, or blue. The onset is gradual. People sort of feel dizzy, lightheaded, roaring in the ears. A seizure, you'd expect it to be sudden, or they may have the aura. Wetting yourself it's not diagnostic of a seizure. And it used to be said that was the case, but people can have enuresis or even fecal incontinence in a faint. So you can't use that as a diagnostic feature, although it is more likely in a seizure. Faints are generally brief. Seizures last a few minutes, but their post-ictal effects can last many hours. And confusion is much more common in a seizure than a faint. So dissociative events are important to mention. So we sometimes call them non-epileptic attacks. Pseudo-seizure is not a term that we should be using anymore. People who have seizures can have non-epileptic attacks, and people who faint can have non-epileptic attacks. And if they have very similar symptoms, it can be very hard to differentiate between the two. There may be a background of significant trauma, psychological or physiological, or ongoing stresses, but not necessarily. You would expect it to be sort of waxing and waning, so people will maybe shake, but it might be sort of asymmetric or slightly chaotic and not something you would expect of a seizure. It might go on for a very, very long time with people having regular breathing, normal oxygen saturations. And quite often people will say that they are aware during the seizure. It feels very unpleasant, very distressing, they can hear things going on around them, and they have dissociated from their body, and that's characteristic of dissociative events. They obviously cannot be treated with epilepsy medication, and the treatment is generally psychological therapies. So what to do if you have somebody who has had a loss of awareness? Well, it's, you do emergency approach if somebody is unconscious, so ABCD approach. If somebody's having an ongoing seizure, use the status epilepticus protocol, and you get somebody more senior who has experienced this sort of thing before, if need be. When the event is terminated and people are conscious and alert, get as much witness information as you can. If an ambulance crew has written down something on a piece of paper, transcribe that onto your clinical records, because if somebody then goes to a clinic weeks later, that piece of paper invariably will be lost, and then we will not have the benefit of the witness account. We may not be able to make a diagnosis. Always do an ECG when somebody's had a loss of awareness, and always listen to the heart. If somebody has neurological deficits, they should really have a brain scan there and then, generally a CT. And if somebody is not fully recovered, do not send them away with a plan for a first fit clinic. And do not send somebody to a first fit clinic if there's not a characteristic history of seizure, if you haven't done an ECG, because if somebody then has maybe conduction block and they're waiting for a first fit clinic, they could then have a significant life-threatening loss of awareness again with cardiac dysrhythmia. It can save lives with an ECG. Because ECG is only a snapshot in time, you might need a 24-hour tape for transient rhythm problems. Cardiologists may do a loop recorder, which will allow events to be captured over several years. If somebody has recurrent seizures, especially if they're new or they have neurological deficits, like I've said, CT imaging of the brain in the emergency department. And do not forget to do an ECG. It's really important. So blackouts are very common. It's really important to try and figure out at source what the patient experienced and what people around them saw. That is how you will make a diagnosis. If somebody goes to see a doctor, a specialist, weeks in the future, and there is no collateral history at all, an ECG isn't done, it's very hard then to know what's happened, and it's very hard to make a diagnosis. It's really important to do baseline investigations, do an ECG. Safety net is important. If you think somebody has had a seizure, they need safety information there and then, and they must have driving advice, and that must be documented. Thank you.